Hi, I'm Darby Santiago. Today we will learn how to distinguish posterior segment causes of blurring of vision from anterior segment causes. We will also learn how to arrange ophthalmic diagnosis according to their importance or gravity. Finally, you will also learn how to manage a patient with diabetic retinopathy in the community setting. So let's begin. You volunteered to be a community doctor in an upland town in Abra, where Aling Melba is a 65-year-old farmer and weaver also lives. She came to you complaining of blurring of vision in both eyes. It first started a year ago in the right eye, and she described it as gradually progressing and saying that it's parang out of focus in character. The blurring progressed until 5 months prior to consult, when she started experiencing the same in her left eye. The persistence of symptoms prompted consult. All right, at this point of your interview, you should be asking yourself, uh, what are the possible causes of Melba's blurred vision? Okay, so I want you to pause the video for a while so you can write down your differentials on a piece of paper. Okay, I'm sure you've written quite a number of diagnosis or differentials, since the history is still very broad. Okay, it's just blurring of vision. You may have written there some probably anterior segment problems like dry eye, corneal scars, ulcer, hyphema in the anterior chamber, perhaps cataract, uveitis or a form of glaucoma, retinal problems, and optic nerve problems. There's actually a lot that you can write or think of. Indeed, when a patient comes to you complaining of blurring of vision, this image should come to mind. Okay, this is what we call the image showing the visual axis. Okay, the blurring of vision can be due to any obstruction or physical barrier or disturbance in any of the path structures of the eye that is within that is within the visual axis, such as that of the tear film, the cornea, anterior chamber, the iris, the lens, the vitreous, and up to the retina and optic nerve. As such, no, when a patient comes to you with a complaint of blurring of vision, you should already, while taking the history, you should already be scanning the eyes of this patient. No, you should be looking for defects in her eyes. I want you to look at your list of differentials, and I want you to think of questions that you would like to ask Aling Melba so that you can retain or remove some of the differentials in your list. For instance, if you're thinking of a refractive problem, you can ask her if she wore thick glasses when she was young. You can also ask her if she's had eye surgery in the past, which might be causing some late complications. Now, if you're thinking of vitreous problems, you can ask her if she sees floaters that blocks her vision. You can ask her if she had eye redness and pain or other symptoms that you can associate with glaucoma or uveitis. Yeah. Now going back to Aling Melba, on further questioning, she mentioned that she has been using a pair of reading glasses, but these two were eventually became useless. She had occasional panghahapdi at pagluluha at pagmumuta ng mata, but this was very seldom. Her medical history revealed that she has poorly controlled diabetes since 2015, hypertension, and previous intake of anti-TB medications. The signs and symptoms and the past medical history of with your history and your gross examination of the eyes of the Aling Melba, I want you to look again at your list of differentials and see if you can add some other diagnosis and remove others. No? You may pause the video so you will have some time to think. Okay. Thank you for doing that short exercise. I too prepared a list and let's see if they jive, okay? I must remind you that there are really no right or wrong answers here. As long as you are able to defend your differentials, then they're okay. For me, the anterior segment looked okay. No? I didn't see any major problems, no? Such as pterygium or scars, no? Except for that photographic aberrations in the left eye. No? Those are just artifacts. So I just concluded that included dry eye because she had a complaint of occasional pagluluha and paghapdi and pamumula. No? But that's it. I included cataract because this is a common occurrence for people her age and because the complaint was bilateral. Because she had a history of intake of anti-COX medication, ethambutol, I decided to include the possibility of a toxic optic neuropathy. Hypertensive retinopathy per se will not cause blurring of vision really. At most, you may have an enlargement of the blind spot if you have a disc edema. But the atherosclerotic changes can lead to vaso-occlusive diseases such as your CRVO, CRAO, BRVO, or BRAO. And these can manifest as sudden blurring of vision. Finally, I included the diabetic retinopathy because she had a history of poorly controlled diabetes. Okay, so to further shorten or confirm our list of differentials, we can now proceed to doing the 5-point ophthalmic examination. As you can see here, the patient's vision improves with pinhole to 20/70 for the right and 20/50 for the left. There was no RAPD and the eye movements were within normal limits. Both globes were soft on palpation, on finger palpation. And upon dilation, which you can do in the community, okay, there are some form of opacity in the lens as evidenced by greenish to yellowish hue of the lens. At this point, I want you to internalize all these findings and look at your list of differentials. You can pause this video if you feel that you need to edit your list. Okay, pause it now. Okay, I also made some editing on my list. So I want you to show it to you in the next slide so we can compare notes. Again, there are no right or wrong answers here, as long as you can defend your list. Okay, I removed dry eye because I realized that this is not really her problem now. Okay, this may be a problem in the past, but right now it's not her main problem. I included error of refraction here because her visual acuity improved with pinhole. I maintained the cataracts because we have confirmed that there is some lens opacity on dilated examination. I am keeping the last three until I have seen the fundus of Aling Melba. All right, so let's get on with it and look at the funduscopy findings for this patient. The top photo shows the right fundus and the bottom one is the left. They appear slightly out of focus or blurry probably because of the cataracts, but there seems to be no vitreous hemorrhage. I want you to look at the optic nerve. That is what a healthy optic nerve looks like with a small cup to disc ratio. The cup to disc ratio is about 0.2 to 0.3. The vessels appear to be following a normal course. Okay, and the AV ratio, they're not tortuous. And the AV ratio is about 1:2. I see several dot and blot hemorrhages in the posterior pole. And there are these yellow hard exudates, especially seen in the macula or near the fovea. Okay? There's more exudates in the right and a little bit less on the left. Does these findings change your list of differentials? You can pause here and write down your final complete list of diagnoses according to their contribution to the blurring of vision or according to the problem's urgency. Okay? So now let me show you my final list of diagnoses. I removed vaso-occlusive diseases because by appearance, they don't jive with the patient's actual fundus photos. I also removed ethambutol toxicity because the optic nerve appears very healthy to me. They're not pale looking actually. I put diabetic retinopathy at the very top of my list because I think this is the most urgent problem that you, as a general physician in the community, must address. This tells you that the patient has very poor diabetes control, and it tells you that she might have other end organ damage already, such as nephropathy, neuropathy, or cardiomyopathy. I placed error of refraction after cataract because even if you give the patient the most expensive pair of eyeglasses, they will be useless because the opacity of the lens will just partially block the entry of light in going to the retina. Also, by removing the cataract, you can put in an intraocular lens with the appropriate power to give an emmetropic endpoint for the eye. In last place is hypertensive retinopathy, which has the least contribution to the patient's blurring of vision. All right. I hope this list contains something, your list contains something similar to this list. Before we proceed to the management, let me ask you a question. When is the best time to screen type 2 diabetics? Okay, I was just checking on you. Always remember to refer your patient upon diagnosis. Do not wait until there is blurring of vision. It might be too late already. So when you go to the community, you gather all your diabetic patients, screen them all, dilate them if you have to, make sure that they don't have diabetic retinopathy. And those that have diabetic retinopathy, you have to strictly control, monitor them, control their diabetes, and refer them to an ophthalmologist at the soonest possible time and when their financial resources allow it. For advanced cases, you have to do everything in your power. If you have to mobilize the community, exhaust all your contacts in the city, you have to do that so that they will be seen and treated by the nearest ophthalmologist or retina specialist in your province. Cataract surgery is not an emergency procedure. In fact, if the patient has concomitant advanced diabetic retinopathy, panretinal photocoagulation must go first before cataract surgery. If the patient is not desirous of cataract surgery, you may advise them to have a pair of glasses be made first. This is more appealing to them rather than surgery, and it is more affordable. But you have to explain that it will bring just limited improvement in vision. It can only improve the vision up to a certain point, which is your pinhole vision. Okay? Finally, you have to monitor the patient's blood pressure and control it accordingly. As a generalist, you should also be comfortable in explaining to the patient what the ophthalmologist might be doing to them. Okay, so just reassure them. Show them photos like this fresh laser marks on the retina, or you may show them YouTube videos of how PRP is being done using a laser machine so that they won't be too afraid. Okay, and these marks, you have to explain that these are fresh laser marks. They're just like blisters of similar to blisters, burn lesions on the skin, which becomes white. But these are painless. Okay, unlike that of the skin. Okay, this is another management that we do. This is intravitreal injection. I suggest you don't show them YouTube videos of how this is being done, because you might just end up scaring your patient and the patient will not go down to the city to go to the ophthalmologist. Okay, you may watch the videos yourself just for your own purposes, no? So that you will know how it is being done. That's it. I hope you are able to appreciate how we were able to zero in on the posterior causes of blurring of vision and how to arrange your diagnosis in an orderly manner according to their importance with respect to management, and how to manage a patient with diabetic retinopathy in the community setting. Thank you and for listening.